Good morning, welcome to our VBAC in Water webinar. My name is Helen and Leonard. I'm a clinical midwifery manager and supervisor midwives at Bedford Hospital.
Hello, and I'm Amanda Puchulski. I'm the same role.
So we're just going to talk you through our stages of our pathway.
So first of all, we'd just like to tell you a little bit about Bedford. Bedford is a relatively small unit. It delivers just under 3,000 babies a year. And way back in 2010, the supervisors and midwives set up a VBAC clinic, which isn't unusual at all in the maternity world. This clinic was run by experienced midwives, but as time went by, and with the release of NICE in 2011, we found that there was potential for women wanting caesarean sections and choosing not to have vaginal birth. But at the same time, what we found is women that had caesarean sections previously wanted to birth normally, and it was how we could help those women have the same experiences that other women were having who weren't regarded as high risk, and that was to have water as a form of pain relief. So what we also discovered at the time was that women were choosing to have their babies in water at home, and some of them it wasn't following a consultation with a consultant or with midwives, it just sort of happened. Of course, we want women to be as safe as we can. So midwives obviously became concerned about this, and sometimes the anxiety was quite great. So we decided that we'd look at giving women the same opportunities as others. So this has been a project that's taken a considerable amount of time. In fact, we're probably 5 years in the making to get to this point, so it wasn't a short and a quick fix. Obviously, when you're designing something that there's not a great deal of research for, which there wasn't at the time, patient safety is a priority. You've also got to look at historical culture within a unit, and because it's deemed as high risk, then consultants and obstetricians wouldn't be or weren't particularly supportive at the time, and of course there was a great deal of anxiety amongst midwives, especially the more senior midwives. So when you're looking at helping women and achieving patient safety, you need to take into account the women's choice. How do we achieve normal birth for those women that have previous caesarean sections? What's the evidence base around the subject? And of course, what are the barriers and how do we improve all that? So we decided that we would use Cotter and Rathberger's 2006. So that's an 8-step challenge, and you can see it up on the screen there. So first of all, the sense of urgency was created because what we found was that women were starting to use the MLU pool, and of course that gave, it was a grey area. We needed to pull together a team that was committed to it, but initially that was small, and that you can see as we go along, develop and change the vision and strategy, communicate the understanding and get people to buy in. And as people came on board, the challenge was to empower others to engage in the process, and also to produce some short-term wins. As you're going along, the challenge is high, and so you need to keep going. You need to keep the focus of keeping patients safe and looking at the evidence that is available, and eventually we're creating a new culture, and we feel that 5 years later we are probably there. So Helen will tell us how we went about this.
Okay, so looking at our first stage using our Cotter model, we looked at creating a sense of urgency. We knew that currently the model that we had was our birthing pools were located at our midwifery-led unit, and these were women on a low-risk pathway. We also know from our best practice and NICE clinical guidelines and the RCOG guidelines that women on a VBAC pathway are advised to birth in an obstetric unit, as this is considered to be the safest pathway for them. We were facing the potential for increased caesarean section rates, since the NICE recommended that a planned caesarean section should be offered for women who chose not to have a normal birth. And currently, as it stood, that women that were on a VBAC pathway, if they wanted to labour in water, they required consultant approval to do so, and that would be at any time, whether it was day or night. So we looked at how we were going to pull together the guiding team, and this was probably one of the most important and probably the lengthiest stages in this part of our process. So initially we had a meeting amongst midwives, and this was senior midwives, any midwife that was interested in the pathway or had any concerns. We had supervisors and midwives present, we had our risk manager present, our delivery suite manager present, and we had a supervisor as well that was impartial, so she wasn't working in the clinical area, so that she could be able to give a perspective and represent midwives' views. So the process of the meeting was to basically understand what the local barriers were for the midwives to be able to move this project forward. So what the midwives came back as concern was that our birthing pools were located in a midwifery-led unit, and that our culture in our maternity unit, as in most units, is that high-risk women have a medicalised model of care, and that's under consultant care and wouldn't be appropriate to be cared for in a midwifery-led unit setting. And we also identified that some senior midwives were strongly opposed to moving forward this project, and that created conflict. So it was basically taking time to understand what these reasons were for the opposition, and just taking that time so that midwives felt that they were listened to and understood. So for the senior midwives' perspective, they were quite concerned that there was going to be a blurring of midwifery-led unit and care consultant pathways, and what they didn't want to happen was women on a high-risk pathway being cared for in a low-risk setting on a low-risk pathway because of the area they were being cared in. Accountability was of a great concern as well for midwives, and they had that fear that if something went wrong, they would be held to account for that. And that was something that we had to take a lot of time just to listen and to spend time answering questions and giving the reassurance where we could. Initially, when we looked at this project, when we started, the guideline that we currently had for the use of birthing pools didn't support the use of water for pain relief for high-risk women. We have since changed that, and I will just talk you through that later on in our presentation. A lack of telemetry monitors for CTG monitoring was an issue, because we knew that if we were going to move this project forward, that continuing monitoring the fetal heart was going to be the most important component of safety for mother and baby. We also found that midwives who were recommending or wanting to support the use of VBAC in water for women were having to discuss with a consultant obstetrician on an individual basis, and this was potentially a problem if it was in the middle of the night and there was that reluctance to call a consultant for that reason. And obviously there was a fear of the unknown. There was little evidence available on the outcomes of VBAC in water, and this was a very new project, and there wasn't any information. There was very little information about other maternity units that may have tried such a pathway. So we had to decide what we were going to do. So our next step was looking at developing a change vision and a strategy. So at this time, both myself and Amanda Puchulski were undertaking MSc modules at the University of Hertfordshire. So we undertook a module Empowering Midwives course. So after this, we had two projects that we led on individually. The project that I led on was developing a VBAC in water pathway, looking at what was the available evidence. And Andy Puchulski then looked at developing a business case for the installation of a birthing pool for women with risk factors on our delivery suite. So what I did at the time was I looked at what the evidence was around VBAC in itself, so looking at the RCOG clinical guidelines, looking at NICE guidelines, and basically doing some research on basically identifying what information was available. I then looked at the water birth and the benefits and potential risks of water birth as well, and what the most current and up-to-date evidence was. And then identified applied a common sense approach to apply the two together to create this pathway. So as a result of that work, we identified that women with one pre-Caesarean section who had a term uncomplicated pregnancy, the BMI at booking that was less than 35, who at the point of being admitted onto the delivery suite, it was spontaneous labour, because the evidence shows that the risk of uterine rupture is at its lowest at 0.2%. providing that if the waters had ruptured, there was clear or just slightly pink stained lycra. Most importantly, that we had good contact on the CTG with our telemetry CTG monitors, because again, the clinical guidelines and our best practices showing that CTG use is the earliest warning signs of potential problems with the scar and potential signs of scar disease or rupture is abnormal CTG in most cases. We also know that from a water breath perspective that the immersion in water aids relaxation, increases regular effective contractions, and that in itself, the evidence has shown, reduces the need for further analgesia. So this is what was the foundations for this pathway. So then we had to also look at training. Whilst it was, one aspect was introducing the pathway and discussing it and putting it out for review. The pathway was sent out for review through supervisor midwives meetings. It was sent out to all the staff list, midwives, obstetricians in our unit for discussions. So there was lots of information, there was lots of discussion, there was lots of little changes that was put into this. So then on the back of that, what the consultants were actually requesting was a criteria for exiting the pathway. So we, again, based on reviewing the clinical guidelines and the most available evidence, we put together a criteria. So we identified that if there's an abnormal CTG, that the woman would be asked to vacate the pool, and that's because it's the most consistent findings in uterine rupture in the RCG studies. If a woman presents with severe abdominal pain, especially if persisting between contractions, if she presents with chest pain or shoulder tip pain or sudden onset of shortness of breath, any acute onset of scar tenderness, abnormal vaginal bleeding or hematuria, a cessation of previously efficient uterine activity, maternal tachycardia, hypotension or shock, loss or cessation of the presenting part, or failure to progress in labour. So then we had to look at deciding what to do. So at the time, the trust had invested in myself and Mandy and also our local supervising authority to undertake this MSc module. So we knew then we needed to install a burning pool on the delivery suite and develop an evidence-based pathway. We also needed to gain collaborative agreement amongst obstetricians, midwives and supervisors midwives and develop a clinical guideline to support this use. We also needed education and training, so this was also incorporated within our skills and drills on the delivery suite. So our skills and drills included emergency evacuation out of the pool using our nets that we have, our sliding sheets. Every member of staff that works in our unit is also shown our evacuation of the birthing pool video. So this was incorporated also in our update week. So we looked at then training our staff, so every midwife, every nurse, every MCA and also student midwives as well would undertake a form of mandatory training. So we were allocated a session during the training to talk through our VBAC pathway, including VBAC in water pathway, care in labour and also the exiting pathway. So then we had to look at how we were going to make it happen. So we needed communication for understanding and buy-in. So we presented the VBAC and water pathway at the Labour Ward Forum meetings, our supervisors and midwives meetings, and at shift handover on the delivery suite. So the education and training for VBAC pathway was probably one of the, again, another really important component that was vital for midwives, nurses and MCAs, and that was to be able to help midwives and all our staff to develop competencies of caring for women using the birthing pool and the VBAC and water pathway. So during the training sessions we spent a lot of time discussing what the differences would be for a woman who was on a VBAC pathway on dry land compared to a VBAC pathway in water. And once the staff realised that there wasn't any difference other than she was just using water for immersion, then the actual anxiety and the worry around this implementation of this pathway just actually fell away. And one of the most interesting things was during the training sessions, I actually wasn't in a position, I wasn't actually training the staff, I was actually more facilitating discussion. And by having midwives from different clinical areas in one room, so we had our community midwives, we had our midwives that have worked on delivery suite, on our midwifery-led units, so all different clinical backgrounds, it actually generated quite a deep discussion. So midwives in the community were sharing their experiences of caring for women at home who were pre-Caesarean section, and the worry that they would have and the difficulties women and choices that women would face to have that birth experience of using water. And then that actually helped the midwives on delivery suite who were very concerned about the potential of things go wrong to actually generate a discussion around safety and where is the safest place for women to give birth. And that really helped to move forward this project and relieve the anxiety and generate discussion and interest in this pathway. And an interesting finding was that the midwives that were strongly opposed to this pathway then changed, become champions to leading forward this pathway. And that really was something that was quite outstanding. So Amanda then developed a business case within the trust to actually find funding to implement and to install a birthing pool on delivery suite. So a business case was put forward to within the trust, and also application was put forward to the Department of Health and charity money to, and we were actually given £20,000 to be able to install the birthing pool on delivery suite and provide additional CTG monitors, the telemetry CTG monitors that we needed for this pathway to be successful. We also had to continue to empower others to act. So the VBAC and water pathway was discussed with women in our VBAC clinic, and that was discussed by midwives, obstetricians and community midwives. We then found that women were choosing the VBAC pathway who were previously undecided or were requesting cesarean section. We looked at how we're going to produce short-term wins. The VBAC in water pathway it remains consultant-led care with the CTG monitoring, and that was really important that we didn't change the pathway to be able to make sure that our staff felt confident about caring for women in the birthing pool. So then we had to make sure that we didn't let up, we had to keep the momentum going. So our first attempt to convert a bathroom into a pool room failed. We had to look at the safety of evacuation out of the pool. We had to look at the dignity of a woman in an emergency situation. And we found that the actual bathroom, we didn't have enough space in the bathroom to be able to install a pool where you could get all the way around the pool. We also found that to be able to evacuate the woman out of the bathroom, we'd have to keep the door open, which then posed a problem for dignity for the woman. So the senior midwives then looked at redesigning the size of the pool and the shape. So we worked alongside a company who designed the pool bespoke to what we needed. So this actually involved the senior midwives getting quite passionate about this, and then what they did is they went into different rooms and they did a cardboard cutout with the size of the pool, and that's how they decided which was the best room for this to be installed in without actually taking out the bed and the equipment that was needed and on an obstetric care pathway. So an alternative location was found in room 4 in our delivery suite. So this is under our consultant-led unit. And then our birthing tool was installed in the delivery suite in the autumn of 2014, but it wasn't until the spring of 2015 that the momentum started with this project. So in September 2014, our VBAC in water pathway was approved and written as a clinical guideline. This was approved multidisciplinary, both within our consultants and obviously within our clinical business unit at the time. This was signed off and approved, so our pathway with the clinical guideline officially went live in September 2014. As we know, a challenge with any new project isn't just getting to implementation, but it's actually making it stick. So it's about creating a new culture. So we're working in partnership with women to develop a positive birth experience. And this has actually seen a change amongst obstetricians actually coming to midwives seeking advice about the best way to advise women who want to use the birthing pools in labour. And this is a big change around. So we're now having obstetricians writing care plans antenatally and having that up-to-date discussion with women. By working collaboratively within our multidisciplinary team, we know this improves patient safety and putting the focus on working with women and helping to achieve the most positive outcome for that mother and that baby. We've anticipated that our normal birth rates will increase, but most importantly, professional confidence has increased, and this has assisted women in achieving choice, empowerment, and a positive birth experience. So looking at the way ahead, our preliminary findings from a recent audit suggest that the pool is being used with no adverse outcomes. A surprise finding is that confidence has grown amongst both midwives and obstetricians. And interestingly enough, we've identified from an audit that women with other risk factors, such as induction of labour, meconium liquor, prolonged rupture of membranes, group strep, and even a set of twins have used that pool for labour and have actually birthed safely in the pool. So the use of the pool for women with other risk factors is now recommended by the midwives and obstetricians, and that is supported with an individualised care plan where it has been agreed that it's safe to do so. And that brings us to the end of our presentation.